Okay, so we're going to talk about age-related conditions. This is for generally toddlers and infants. And the first one we'll talk about is bronchiolitis, which is inflammation of the bronchioles, and that's generally due to a viral infection, and that can be just as simple as the flu. Again, this is for toddlers and younger, and the signs and symptoms are very similar to asthma. And then we can get into RSV, which is a very significant cause of illness in young children. It's highly contagious, and you will see it will run rampant through a demographic of children when they're in places like daycare and the like. And this is why a lot of kids who are very young and have communal care will pass that kind of disease process amongst one another, because they're all playing and exploring and touching, and they don't really have the hygiene or the ability to say that they have this illness before it's caught on to the rest of the children. Croup is another inflammation, and that's swelling to the pharynx, larynx, and the trachea, and it's usually secondary to that upper respiratory infection or the viral infection load. And this is seen in children as young as 6 months to 3 years of age. This as well is easily passed. It starts with a regular cold, they have a cough, a low-grade fever, and then they start to have a stridor when they're breathing, and then they'll have this seal-like barking cough, and that's because of the tissue that is now swelling and secreting extra fluids, creating an occlusion to the airway. And so their way of actually getting this to exhale is to cough. They create their own PEEP to override the swelling of the tissue. They can respond well to humidified oxygen, and in the case of ALS or the physicians, there are drugs that will also help take the immediate swelling down from the airway. Epiglottitis is inflammation. When you guys see itis, this is inflammation, and the epiglottis again is that flap of skin that separates the esophagus from the trachea, and as you swallow, the epiglottis or above the glottic opening is pushed down, and it folds over to keep you basically from inhaling anything when you swallow. When this tissue becomes inflamed because of a bacterial infection, it can become significantly painful. These patients will tend to want to sit with their mouth open. They'll kind of have their tongue hanging out because they're trying to keep their epiglottis from obstructing the airway. They're going to be drooling and things of the kind of sort. You'll hear a high-pitched inspiratory sound because of the inflammation of the tissue right around the airway. Pneumonia can affect anybody from any age, and the bigger risks are children and the elderly. And pneumonia is quite simply, that's really just a actual infection. And so that patient has an infection in the lungs, and they're secreting fluid due to the white blood cells that are trying to attack the actual infection. And so the reason that very young children and elderly are at risk is because they don't have a very highly developed immune response. And so this infection can actually get out of control, or the immune response will over stimulate, and that will actually kind of create a worsening condition for them. Some of their signs and symptoms are fever and chills. They have a productive cough with sputum, and then they have that pleuritic chest pain, and then they have excessive mucus causing a pulmonary consolidation, which is kind of a plug. Pertussis is the whooping cough. This is an airborne bacterial infection. Most people have been vaccinated against this. It tends to infect children that are very young who have not had the vaccination yet. It is also highly contagious. Most new parents will get another pertussis vaccination when they're just after childbirth, just to make sure, or the like. Cold-like symptoms, but they will have very significant coughing spells. A parent may call 911, especially if they're a new parent, because they cannot figure out why the child is doing what they're doing. And so then when we move into airway obstructions, you want to consider a foreign body when a child becomes short of breath. And this could be anything from intrinsic, right, meaning that it's part of the body that's creating the airway obstruction, or it can be a foreign airway obstruction, right, because children like to explore things with their mouths. They may swallow something that becomes an obstruction. Children who have some kind of tonsillitis or inflammation of the oropharynx can actually occlude the airway as well, because remember, their structures are much smaller. So a small increase in size due to inflammation can be a significant occlusion. They may have some kind of tracheostomy dysfunction, like tracheomalacia, where it's a flaccid trachea, and the obstruction may actually be in the lower airway, which is below the vocal cords. Pretty typically, you're not going to see very small children who are going to have CHF. This is going to be more the older population or your elderly population, or somebody who has suffered a heart attack, which would be the acute event, creating the chronic heart failure. The heart is failing as a pump, again, because the left ventricle is unable to push fluid against the systemic vascular resistance, and then this results in pulmonary edema. Why? Because the fluid is backing up in the lungs. The risk factors are obviously hypertension, they've had coronary artery disease and or atrial fibrillation, which all of these kind of lead into that, but generally you have two forms of CHF, and that's the AMI-induced one, which is where we've lost a big swath of the heart tissue in the ventricle, or we have the chronic one, which is the lifelong history, I should say, or significant history of hypertension, and then the cardiac tissue becomes thickened as it grows, trying to meet the demands, right? The heart's like any other muscle. If you work it out continuously, it's going to grow, and unfortunately, the heart tissue is not very keen to grow very large, because the thicker it gets, the less volume we have in that left chamber, and the less elasticity we have to that tissue, and so the ejection fraction then falls as well, and we're unable to actually pump against that vascular resistance. These patients are going to have difficulty breathing with any kind of exertion. They can have sudden attacks of respiratory distress, and that's because of that flash or acute pulmonary edema. They're coughing because they're trying to move that fluid up out of the lungs. They feel like they're drowning or they're being suffocated. They'll have cold sweats and tachycardia as the epi-dump for their survival instinct kicks in. So you guys have heard me say this when we're talking about primary assessments. Respiratory is one of those things that you guys can initiate right across the room. When you guys walk in, if somebody's altered, that should be a red flag. If you're looking at them and they don't look like they're pink, warm, and dry, that should be a red flag. This is across the room assessment, and then look at the way that they're breathing. Do they look like they're breathing normally? Now, normal has a range. We typically say it's 12 to 20, and then we're looking for adequate tidal volume. Like, are they moving the appropriate amount of air? And it is almost as simple as which one of these doesn't belong. When you walk into the room, if they look like they're working to breathe, they're probably working to breathe. If they look like they're not breathing at all, they're probably not breathing at all. Don't get caught up in the numbers. Look at your patient and determine what it is that they're doing and how you can best assess their ventilation. Some of the telltale signs when you're actually making contact with your patient is, are they able to speak in full sentences? Are they moving enough gas that they don't actually have to ventilate to where they're in a 1 or 2 word sentence dyspnea? Are they coughing? Are they tachycardic of more than 130 beats a minute? A slight stress response will make somebody, like, clinically defined as tachycardic, which would be a pulse of over 100. But if we're at the 130, 140 range, and we're thinking that it's tied into the fact that they're having dyspnea, that is a key indicator that should raise up that red flag 1 notch. If they're using their abdomen to breathe, that means that they're using accessory muscles. Their diaphragm is now becoming tired, and they're doing everything that they possibly can to try to create that negative pressure to get airflow in. Their respiratory rate is increased or decreased, and is the rhythm regular? Most people, even if they're breathing quickly, will breathe on a regular interval. If it's irregularly irregular, we know that we have a significant problem, and it's generally tied to some kind of traumatic brain injury. If they're diaphoretic and they have that pale skin or that dusky look, right, we know that they're not perfusing, so they're basically in a state of shock. If they have retractions or they're using those extra accessory muscles, right, you're going to see it in the neck, the sternocleidomastoids, anything along the rib cage. If you see that, they're using those accessory muscles as well. If they're tripoding, like you guys saw in the picture of the guy with COPD, that patient is using mechanical function to create less resistance in their breathing pattern. So these are all telltale signs. This is nothing that you guys haven't seen before, and I want you to just kind of remember when you walk into a room, this is very easy to assess from across the room. Lung sounds are going to come after you make patient contact. Make sure that you're making that general impression. When you walk in, one of the first things you should be doing is, do they have respiratory distress? Note that the position of the body that they're in, right? If they're laying flat on their back, generally, if they're unconscious, they may have respiratory distress. But if they're awake and they're laying on their back, they're generally not going to have that significant respiratory distress. We're looking for that patient that wants to get up. They're putting themselves into a position that's going to assist their ventilation. Look at their responsiveness. Is their mentation altered? If it is, we need to go down that AEIO tips algorithm and figure out why. Is it due to hypoxia? O2 saturation should help you figure that out as well. And then ultimately, if you can get them on end tidal, you can actually see a lot more than just what the O2 sat probe is telling you. Determine if their airway is open and clear. If a patient's talking to you, their airway is open and clear and they self-maintain it. If they are obtunded or have a decreased LOC, they're really not going to be able to support and maintain their own airway. They're very high likelihood to have some kind of aspiration event where they vomit or something of the like that they're going to inhale. This could be blood, saliva, or vomit. So make sure that you understand that you're looking for that. If you're looking at the rate at which you're going to ventilate, you guys have heard me say through class, in pediatrics it's breaths every 3 to 5 seconds, and in adults it's breaths every 5 to 6 seconds. The easy cut through path on this one is every 5 seconds. Ultimately, you want to have this person on end tidal. We're looking for values and waveforms. That should dictate everything that you're doing. You want to have that end tidal CO2, capnometry. It's going to be between 35 and 45, and a nice square or table-topped waveform. When we're listening to breath sounds, there's several key locations that you want to do this on. And remember, this isn't the end-all be-all, but this is a general way to know that you're in the upper lobes and the lower lobes. And I want everybody to pay careful consideration to the fact that you don't see the bell of the stethoscope over the top of the sternum, right? We're not going to try to listen through bony prominences to get breath sounds. They're trying to avoid the scapulas or the shoulder blade in the back. So you can see that they're pretty down low and deep and away from the shoulder blades, and they're just central or midline from the shoulder blades, kind of along the spine, trying to catch those upper lobes from the back. Again, history taking is paramount for any of your respiratory cases. If you have somebody who's alert or you have somebody there that actually knows the history, get all the history you can, because the past medical history is more often than not going to help you figure out what's happening today. The history of present illness may be a tragic or spontaneous event, but generally respiratory problems are something that are chronic problems that have progressed to the point where you're making contact with that patient today. In regards to a secondary assessment, we want to make sure that we have vital signs, do a very hands-on assessment, look to make sure that you see adequate chest rise, that you have somebody who has bilateral chest movement, and that there's not a traumatic injury. You want to absolutely know whether or not you have breath sounds in all the fields that you want. Remember that spontaneous pneumo. We want to know for sure whether or not that patient is collapsing a lung. So if we have a decrease in breath sounds on one side, it's a telltale sign. So monitoring devices, this is pulse oximetry. Peak flow meters are not generally used in the field. And if they are, I don't know of any in our particular area, but end tidal CO2 is pretty much available to everybody. It is one of the gold standards for respiratory complaints, and is going to be one of the best tools that you can use on anybody with a respiratory component. Anytime that we're going to do a treatment, the general rule is all patients deserve an assessment. Not all assessments deserve a treatment, but any treatment deserves a reassessment. And so this is in regards to any treatment that you do or any drug that you administer. Make sure that you reassess and you're getting the desired effect out of that. If you're not, we're either chasing a wrong problem or something is being ineffective. So we want to know that stuff when we get to the receiving facility. You have to be able to say my patient responded or did not respond to these treatments so that they have a better idea instead of reinventing the wheel and trying to do your treatments over. In regards to fluid balance, what I want everybody in class to remember is that anybody that has a respiratory component, if we're going down the algorithm of CHF, if you have a patient who has wet lung sounds, we do not want to increase the fluid volume. We do not want to increase that fluid overload on that patient. So make sure if you're going to start an IV and you're giving some kind of IV access and fluid administration, that you're very adept at your assessment before you give them the fluid challenge. Okay, so in regards to assessment management of that acute pulmonary edema, this is CHF exacerbation. CPAP is one of the most wonderful tools that we can use. There's just a few parameters you got to keep in mind. Your patient has to be able to protect their airway, or you are going to protect it for them. They have to have not had significant like surgery or trauma to the esophagus or the airway previous to you applying it, because we do not want to create a worsening condition. And they have to have a blood pressure of at least 90, because when we actually inflate those lungs and we get them kind of consistently inflated, we're going to put a little pressure on the heart against the vena cava. This could choke off blood flow. So if they're already hypotensive, this is flat out a no-no. No CPAP to somebody who's hypotensive. 90 systolic or better. Okay, so that's the end of the lecture. I've shortened up some of the slides because we've talked about many of these already, and there's a lot of the same information that just kind of gets rehashed. Remember that a true respiratory complaint is a life-threatening event, and that we have to treat these aggressively. But we don't want to be just off the hip, right? It's not just throw oxygen on everybody and hope for the best. Use history taking and your assessment to drive your treatment. Make sure that you're utilizing the right devices, right? End-tidal CO2, CPAP, supplemental oxygen, and the correct drugs can ultimately create a wonderful condition for the survival or the outcome of the patient. So if you have questions, make sure you get them to me, and if not, we'll talk more about it in class.